in between. So welcome again, once again, Dr. Mahesh Gupta, sir, for being with us at 3D series at Indore. And we will love to talk because of your expertise and your intervention techniques and how your surgical skills are good for everyone who will listen it, because this recording will be on the YouTube and people can learn many more things from you. And so again, once again, your contribution to the medical community is invaluable. So over to you, sir. First question I'd like to ask, anything which you want to say to all the audience, then we will start the audience. Then we'll start.
Before you ask a question, I must tell you that if you promise me to give two friends like Asha Bakshi and Arshana Baser to me in Indore, then I am ready to shift to Indore from Ahmedabad.
Thank you so much, sir. Thank you so much. I am privileged and I am spreading this point to each and everyone that I have that two backbones in my place. Thank you so much, sir.
Thank you.
Thank you so much. So over to you. Can we start the dialogue? So, sir, our is a very crisp and a very 10-15 minutes job, because we don't want to make it so large and anything. And anything which you want to add on your point, I'll be happy. So how can obstetrician prepare, number one, and anticipate the potential complications of postpartum hemorrhage? Because postpartum hemorrhage, we all talk so much about postpartum, but the important point is when a person like you will give the insight on this subject, that will be definitely a different than what we have learned before. So over to you, sir.
Yeah, see, the postpartum hemorrhage from the postgraduate days, it has created so big scene and it is so scary. So now to come out from that gloomy atmosphere of the PPH, if you mentally prepared or if you anticipate certain cases in which the PPH is more likely. As in RCOG guidelines number 52, RCOG has identified certain cases which called as a PPH precursor cases. In those cases, there are chances of the PPH are more. So if you are mentally prepared for those, when you are dealing with those cases that PPH is likely to occur, then how to tackle that case? So mentally you should be prepared. It is just like driving a car on the highway. Suddenly some obstacle come in your way. You are totally confused what to do. But if you anticipate that our further four-wheeler may have a brake, so you are mentally prepared to brake your vehicle also. So that is about the anticipation. So anticipation is very important. And second thing is certain cases where there are the sporadic cases which likely to bleed. Now, how to follow up that cases and how to manage that case, we'll discuss later a part of our dialogue.
Discussion.
So anticipation and preparedness is always important as far as the PPH management is concerned. Because in the midst of the PPH, when your brain is occupied, you are clumsy, so you will not focus properly. So once you will prepare mentally and you anticipate the cases, then it will be easy to manage that case.
Manage the case as well as it. So you mean that we should have a good, correct checklist and everything, and prepare our mind also, and prepare every environment and everything, and anticipate all the potential complications of this. Amazing. So what are the basic? See, it's a very basic question, but it will come. The answer will come through you. It will be really good. So what are the initial steps we should think about involving the management of PPH?
So if we divide the PPH in two portions, one is a normal delivery, then PPH, and second is PPH during cesarean section or PPH after cesarean section. So now PPH after normal delivery, here you are probably you are alone. So what you will do, as soon as you diagnose the PPH is there, then it is not like a British or American protocol that you will call for shout and you will call somebody. No, in your operation theater or in your labor room, you have a limited staff. So you will identify the PPH, and what you will do, you will just, after normal delivery, you will clean the vagina, you will clean the uterus with the finger. You massage the uterus. Meantime, your assistant will start the ergotonics, and whatever the ergotonics you will use. And meantime, they ask for the anesthetist and ask for the pathology. Anesthetist is needed to explore the vaginally, because many times it is confusing that this PPH is traumatic or it is atonic. So meantime, the anesthetist will come, then you can explore the patient. And now after normal delivery, there are conventional modalities like balloon tamponade, or some say it is suction cannula. But these are not, I give you a point of caution that these are not 100% curative treatment. But you can certainly buy a time for a major event. If you are using a balloon tamponade, if you are using a Bakri balloon or condom tamponade or any cannula, then you can buy a certain time to arrange for the further, if needed, either laparotomy or surgical management of the PPH. Now, in case of the cesarean section, during cesarean section, if you find, like I told you that RCOG guidelines number 52, where all the cases, PPH precursor cases, like multiple pregnancy, like a big baby, like prolonged second stage, like obstructed labor, like pregnancy conceived with the ART, history of APH, severe preeclampsia, all these cases need cesarean section. So when you are dealing with these cases, during cesarean section, you should be extra watchful and careful, and you should be ready with some kind of interventional surgery or PPH tackling surgeries along with the cesarean section.
Correct.
So that is a two scenario: one after normal delivery,
one after,
and one during cesarean section.
Correct. You are amazing. So basically the initial steps at whatever the setup you are working is another important point. It should not be like that each and everyone in this country will have the high-ended setups with so many checklists, the blue call, the blue code, or the all the code. They should be there. The staff should be trained. But at any setups, the two things which you have talked about, one is about the normal delivery, and other when we are doing in a cesarean section, all the Bakri balloon and all the this cannulas should be available. Good, sir.
And certain cases when you are going for a cesarean section, like severe preeclampsia kind of thing, then you must have a preliminary complete blood count and complete PT, APTT, INR. So if there is a little deviation in this coagulation profile, then again you have to infuse this kind of blood and blood products beforehand going for cesarean section. Otherwise, cesarean section may lead to the worsening of that mild coagulation failure to a full-blown DIC. So in those cases, I suggest that you go for preliminary serum investigations.
Correct. So you mean the right preparedness is very, very important. Now, always we talk about so many things. So is there any difference between the active management of the third stage labor, or that is versus what active management is needed into the fourth stage of labor nowadays, which we talk about? So in a PPH, both the things are there. We need management, and actually what difference you feel there is a difference between these two managements?
See, active management of third stage of labor, we are being taught and we are teaching and we have been learned since many years.
Correct.
So basically now we should understand that active management of third stage of labor is for prevention of PPH. It is not a treatment.
Yes.
It is a prevention of the PPH. So now that we have achieved, now everybody is giving some kind of oxytocin in third stage of labor, maybe at the anterior shoulder, maybe at the after coming head, or maybe after delivery of the patient, by any means, but everybody is giving the oxytocin. Now that is a prevention of the PPH. Now more important is a fourth stage of labor.
Correct.
The fourth stage of labor is called a post-placental 1 hour. So post-placental 1 hour is a fourth stage of labor, and most of the time, in other language we say as a golden hour for PPH management. So that is the fourth stage of labor. Now, if you are a watchful, or if your staff is a watchful in fourth stage of the labor, then most of the PPH can be picked up at early stage.
Correct.
What happened after normal delivery? Once you complete everything, episiotomy and everything, you come and start looking your OPD, and after half an hour, the staff will come that patient is bleeding. Or in case of cesarean section, patient has been shifted to the room, and you are relaxing, you are taking your tea and coffee, and meantime, the staff will come that patient is bleeding. So post-placental 1 hour is very important as far as the PPH is concerned. So if you are watchful in that post-placental 1 hour, that is called a fourth stage of labor, then most of your PPH can be easily tackled. That is a one thing. Now, second thing, I promote active management of the fourth stage of labor in cesarean section. And what is that? As you are doing or as you are giving oxytocin in prevention of PPH in third stage of labor, the same way you have to go for prophylactic surgical management of PPH during cesarean section in fourth stage of labor.
Correct.
Wherever you find that this patient may bleed, most of the time we heard that the twins pregnancy cesarean section done, and evening there was a severe bleeding, then obstetric hysterectomy done. Morning for severe preeclampsia or HELLP syndrome, the cesarean section done, and evening again re-exploration done. So in fourth stage of labor, we should adopt a technique to control or to prevent the postpartum hemorrhage. That should be now propagated. Because it is not simple that all the time you open the abdomen, take out the baby, close the abdomen, and shift to the ward.
Yes.
All the time it should not be done. You have to now be a little more cautious and more watchful. And now all this uterine artery ligation, all compression sutures, they proved beyond doubt that it doesn't affect the future fertility. Now it is proved beyond doubt that either uterine artery embolization or internal iliac artery embolization or uterine artery ligation or internal iliac artery ligation or various compression suture, they will not interfere in the future fertility. Then why not to do during cesarean section if you find a little doubt? That is a basic difference between third stage and fourth stage of labor.
Correct, correct. So we have to be very much alert, prepared, and able to manage many more things into the fourth stage of the labor, as you have suggested all about it. But what are the basic interventions like a general OBGYN? They should be able to do it. It's not like that always you have to call some skillful person or something like that, like you, but a general OBGYN who are able to do the different types of intervention, they will call all the senior people or the second opinion person soon. But before calling or before giving a referral or anything like that, means in between the time, they should know some interventions that
exactly
to manage.
Exactly.
That's what I feel.
Referral to the hair center is some form of escapism, what I feel. It is escapism, yes. Some kind of escapism. Yes. Yes. A person who can do a cesarean section, they can easily ligate the uterine artery. They can easily do the compression sutures. They can easily do my KMG. Now, one more important thing is that we have been traditionally taught the 4 T's are responsible for the PPH, that is tissue, thrombin, trauma, and tone. But for me, the management of the PPH, this 4 T's is to be now put in the museum. We have to identify the bleeding is from either upper segment of the uterus, that is atonic hemorrhage, whether the bleeding is from lower uterine segment, that is the bleeding after the placenta previa or placenta accreta, or bleeding is due to a trauma to the genital tract.
Correct.
So upper segment bleed, atonic PPH, lower segment bleed, the placenta previa bleed. Yes. And if these two bleeds are not there, that means patient has some trauma. Correct. It may be in the form of vaginal wall trauma, it may be colporexis, it may be rupture uterus, it may be broad ligament hematoma, it may be extension of the uterus during hysterectomy incision. So if you identify basically quickly that it is atonic PPH or lower segment PPH or traumatic PPH, then 3 sets of the surgery you should know. Correct. In upper segment, this uterine atony, the set of surgeries are there. You should promptly do that. If it is a lower segment bleed during cesarean section, different surgeries are there. You should adapt that surgery. If both the things are not there and still patient is bleeding, then you have to treat as a traumatic PPH. In traumatic PPH, the different surgeries to be done. Correct. Because most of the time, all the senior gynecologists are mostly talking about the internal iliac artery ligation. That I have seen. Because I'm doing the PPH conference, so most of the senior, they send me the video of internal iliac that I want to show this internal iliac. I tell you that only internal iliac artery ligation only has no role in atonic PPH as well as in lower uterine bleed PPH. Only internal iliac artery ligation has exclusive and very important role in traumatic PPH. If there is a trauma to the vagina or cervix and you can't tickle from below, internal iliac artery ligation is a definite role. Yes. If there is a broad ligament hematoma or supralevator kind of hematoma, the internal iliac artery ligation has a role. Because in placenta previa acreta, the gravid pelvis, there is exclusively remodeling of the pelvic vasculature in placenta acreta. All the branches of internal iliac, they anastomose with the branches of posterior division of the internal iliac, branches of the femoral, branches of the external iliac, and branches of the aorta. So if you ligate the internal iliac, temporarily there will be bleeding will stop, but after few minutes again the bleeding start. So we should not jump for the internal iliac artery ligation alone in cases of atonic PPH as well as in lower segment PPH. So that is the basic difference.
Correct. So other intervention means right from devascularization of all. You can start right from the uterine artery to the
simple. It is a atonic PPH.
Yeah.
If it is a atonic, meant it is a upper segment bleed. So upper segment bleed is basically a muscle is at fault.
Yes.
So if muscle is at fault, then I have developed a technique called compression and occlusion of the uterine artery. I am doing the compression of the myometrium as well as the occlusion of the uterine artery with a single puncture on one side. So that gives the best result, and we have many publications for that. And at present, in 5 medical colleges, the dissertations are going on for this topic. Now, if it is a lower segment bleed, in lower segment bleed, only uterine artery ligation will never work, because there is extensive anastomosis with the vesical branches, with the pudendal branches, with the vaginal branches, with everything. So in lower segment bleed, you need to have some kind of cervicoisthmic suture. So if you take a cervicoisthmic suture, then bleeding will be easily stopped. Because nowadays, in placenta acreta or even increta, no need for obstetric hysterectomy. We have kept a separate session that no hysterectomy in placenta acreta. Because in Gulf countries, the hysterectomy is not allowed. So they have marvelous techniques to control the bleeding from the placenta acreta bleed. They remove the placenta and they conserve the uterus. So since last many years now, we are conserving the uterus. We are not doing obstetric hysterectomy in all cases of lower segment adjacent placenta. It's not needed. And temporarily, all the gynecologists should learn the temporary tamponade in lower segment bleed in the form of either Follis catheter or in the form of Satinsky clamp. You apply a Follis catheter in the lower uterine segment by puncturing the broad ligament on either side, tie a Follis catheter, all bleeding will stop. Then you can take your call, either to call a senior or you can gradually go for a devascularization of the lower segment.
So everybody is always impressed and seen your surgery as well as teaching in many workshops, and everyone, your technique of Mahesh Gupta's technique of managing postpartum hemorrhage is also popular amongst all the practicing OBGYN, that how you have used the condom catheter and how the bleeding vessels of the uterus, and the way of teaching is always, we all are impressed by the way you put the things, and it's very important topic. And the best part is the innovation of your innovation is not that costly one. That's another important, the country like us, where we want to reduce the maternal mortality at such a level, and we don't want that they should be in a very costly things we need. So another, any other point which you want to talk about your technique regarding, we all know most of us, and we'll like to listen from you.
Basically, I developed 3 techniques.
Yeah.
Two of them were published in 2015 in the International Journal of Gynecology and Obstetrics. That one is a popular, this is a compression and occlusion Mahesh Gupta technique, that is COMOC-MG. So in COM stands for compression of the myometrium and OC stands for occlusion of the uterine artery. Because if you see individually, if you are going for only Billings in PPH, then the success rate is 80% to 90%. If you are going alone uterine artery ligation, then again the success rate is 75% to somewhere around 90%. But if you are going both things, then success rate is 100%, almost 100%. If it is done in time. If you are wasting more time and then uterus tissue become edematous, then compression will not help. Then only obstetric hysterectomy is the option. So in PPH, one more thing, the bleeding is neither venous nor pure arterial. It is a mixed kind of bleeding. So you have to cut down the blood pressure in the uterine artery. That is one thing. So by cutting the blood pressure at the ischemic level in the uterine artery, you will get a maximum effect at the endometrium level. So that bleeding will become more venous. And that bleeding controlled by the compression of the myometrium.
Okay.
So with a single puncture on one side, one right side and one left side, you can do a 2 modalities at the same time. And it requires hardly 5 minutes. And special suture materials are also available in the market for the same surgery. Why B-Lynch is still not popular? If you ask 100 gynecologists, 100% knows B-Lynch.
Yeah.
But 90% have not done B-Lynch in their life.
They never tried it.
Yeah, because it's little clumsy. It's little clumsy and proper suture material is not ready. So I made a suture material separate for this surgery. So the things will become very easy. And second is the in placenta previa bleed. If you don't know anything, just if you can separate the bladder, the use of Satinsky clamp, Satinsky urological clamp, it is used for a nephrectomy.
That can be.
But its shape is such that it can be easily accommodated in the gravid pelvis. So after making a little space in the broad ligament, that Satinsky clamp will be pushed down. And at the level of cervix, you apply through Satinsky clamp, and it has a 7 catch. If you use only 3 catch, then it will just occlude. It will not crush the tissue. Okay. So bleeding will stop. So that was my one more invention. Yes. And third thing, if you don't have anything, then just make a hole with a cautery in the broad ligament as low as possible. Pass a Follis catheter tight.
Yes, yes.
So all the seniors, they are teaching that there is a massive hemorrhage and there is a hemorrhage. Nothing like that. I can show you all the videos for that.
I'm sorry that I'm just putting my word to the audience. I'm sorry to, yes, sir. Yeah. I'm sorry to all the audience that it's only the dialogue we are doing it. And definitely you can see all the Dr. Mahesh Gupta's videos at Ahmedabad program also, because he's having a big conference over there on PPH. And another point is already on the YouTube and everywhere they are. As well as some program, we will call it and add it, that thing with our some other program we can see your videos.
The most important thing to me for PPH is just to remove the thought blocks, just to clear your mind. If you remove your old thoughts, then if you do something new and new things are there, there are plenty of videos in the YouTube. You can easily see that. But you remove the mind from the mind that, oh, it is a very
mind. We just want to change the mindset. What is in our mind and what we want to. So the last question everybody would like to know about, that when and where should the patients of PPH should be referred for the additional, because we are talking all those things you are talking about.
That is very important. That is very important. Today only, with the Gujarat government, I had a meeting for maternal death review. MDR meeting was there today morning at the 11 o'clock, and each state government is now very particular about the maternal death.
And maternal
Every government is now serious. They are starting internal audit, and gynecologist has to face the question from the government if there is a maternal death.
Absolutely.
So now this question comes that when to refer.
Yeah.
Most of the time, what gynecologists do, that just to save their skin, they refer the patient. They are not thinking that where they are referring the patient, at this place, the proper infrastructure is there or not, proper person is there or not. So now what happened in our Gujarat, just last week, 2 deaths were there because of the shuttling of the patient.
Yes.
I call it the shuttling.
It's so shuttling.
So patient went one place, so-called ICCU was there, patient was operated again. Third gravida, PPH occurred, gynecologist did obstetric hysterectomy. Bleedings continue, patient referred to another hospital where the ICC facilities were there. Again, patient second day operated, laparotomy done. Hemoperitoneum was there. Again on third day, patient referred to tertiary care.
Correct.
For same hemoperitoneum and bleeding period. So now it is very important that where you are referring your patient, and that hospital is properly equipped with all the facilities or not. Because this shuttling of this patient, definitely patient is going to suffer a lot. The morbidity will be very high. So it is very important you find out your nearby, that whenever you want to refer, if in your hospital you have an anesthetist number, you have a pathologist number, you have a radiologist number, same way you have this kind of hospital number also, and you find out the person who can tackle that case. And you involve, it doesn't mean that any hospital is big hospital, but may not have that gynec facility proper.
Correct. Absolutely.
Ultimately, patient suffers, and that patient, when the second, third reference patient die, then the legal complications are more. So every gynecologist must be fully equipped to tackle the case at their place as far as possible.
Correct. So it's a way that you can put in such a nice way. And the maternal mortality of Madhya Pradesh is so high, and that we are worried about. We are second last number in the whole country, and we feel bad about it because the number one reason is the not referred at the right time, and where to refer at such a time, that the way you talked about.
Exactly.
That's very, very important. And in a PPH, we need a comprehensive approach, as you have said, about preparedness, anticipation. We need a proper management of the third stage and a close monitoring, and to learn by each and every OBGYN the simple techniques which they can learn. It's not tough to learn many things which you have talked about, I think. And while referring, we should know the determination of the level of care they have, where they are sending. We should save ourselves medico-legally by obtaining the right consent, which I always feel about. And
because nowadays now recombinant, the factor 10 is available. Recombinant fibrinogen is available.
7 is available.
Recombinant prothrombin factors, kind of the 2, 5, 6, some, they are also available.
Yes.
So now we are not dependent on this human FFP or human cryo or human this all the time, because these are now available in the market. We have factor 10, we have this fibrinogen. It is costing only 15,000.
Yes, absolutely. So it's all our responsibility, especially to communicate with the patient and with the attendants also. And the most important, we are supposed to take the proper follow-up. What I feel that once the patient has been referred anywhere, follow-up is also important. Be there with the patient. Don't leave the patient. That's always I feel. And if that will save our skin also, and we can save the patient also. So thank you so much. Any concluding remarks which you would like to talk about? We will love to have, and that we can stop the conversation. Thank you so much.
It was a nice dialogue, and PPH is
we love the subject.
Is a subject which is very dear to me, and I'm always working for that. And I'm being people have trust in me. So half portion of the Gujarat, they are referring all these cases to me every day. So I'm tackling this. That's why I'm giving this extempore advices.
Yes, absolutely.
What to do this gynecologist in cases of PPH.
And we all Indoris always admire you, to call you at our own person for the workshops and everything. Thank you so much for being